All right, so now we go to our sixth oral abstract, and this is from the University of California, Davis, and we're going to have Callie Roberts speak to us. UC Davis, as you've already heard, Dr. Victor Huang has a vitiligo center there. It's very exciting. He started this just a few years ago, and they're already doing lots of great research. And so today we're going to hear from their department on the risk assessment of internal malignancies in patients with vitiligo.
Hello, my name's Callie Roberts, and I just finished my second year of med school at UC Davis. Dermatologist Dr. Victor Huang and I have been working on this research project to examine the risk assessment of internal malignancies in patients with vitiligo, and we are excited to share some of our first findings. So to begin, vitiligo is a skin disease characterized by the progressive depigmentation caused by immunologically mediated melanocyte destruction in the epidermis. And studies examining disease associations in vitiligo have focused primarily on associations with psychiatric and autoimmune conditions. But there have been some large studies that utilized Taiwanese and Korean national health registries, and these have demonstrated that there may be associations with cancer risk related to vitiligo. However, results to date have been mixed. So here we'll present data from a retrospective analysis of cancer risk in an ethnically diverse patient population while controlling for potential confounders that are difficult to address via national health databases. So our research objectives were to build a database of patients with vitiligo to study different questions, such as do patients with vitiligo have different rates of internal malignancies compared to patients without? And does having segmental versus non-segmental vitiligo affect a patient's cancer risk? So to methods, the study overall is a retrospective cohort study using data from the UC Davis electronic medical record. And during our chart review of 1,484 vitiligo patients, we recorded the laterality of their vitiligo, vitiligo type, date of diagnosis, date the patient first noticed their vitiligo, phototherapy treatments, and if the patient had a diagnostic code corresponding with a cancer event, then we logged the date of all the cancer diagnoses and types, and if the patient had undergone immunotherapy. So for the 3,086 age and gender matched controls, we selected patients who had a primary care doctor at UC Davis, and if the patient had any diagnostic codes corresponding with cancer events, we logged all the cancer types too. And for each cancer type, a logistic regression model was created and an odds ratio was calculated from each of those logistic regression models. So for time's sake, we'll skip over some of our raw output data here in these two slides, and let's move on to discuss some of the key results. So our model showed that vitiligo patients had an increased prevalence of breast cancer among females, prostate cancer among males, and liver cancer and leukemias among all patients. And of these, the only nearly significant result was leukemia. Our model showed that vitiligo patients have a 43% higher risk of getting a leukemia compared to non-vitiligo patients. And we also found that vitiligo patients had a decreased prevalence of any solid non-skin cancer, one cancer of any kind, more than one cancer, a recurrent cancer, and metastatic cancer. So however, of those, the only statistically significant protection for vitiligo patients was from a recurrent cancer. In fact, non-vitiligo patients were 2.65 times more likely to have a cancer recur. Furthermore, the vitiligo patients had a decreased risk of the following cancers, so non-melanoma skin, ovarian, testicular, thyroid, lung, colorectal, kidney, ureter, bladder, lymphomas, pancreatic, esophageal, stomach, mouth, and brain. And so of these, the only statistically or nearly significant result was with kidney cancer. Our model showed that non-vitiligo patients have a 4.47 times higher risk of having kidney cancer compared to the vitiligo patients. And interestingly, the prevalence of pancreatic, esophageal, stomach, and testicular cancers was 0% in our cohort of vitiligo patients. And from our logistic regression model, we determined that non-vitiligo controls were at least 2.4, 2.7, 3.6, or 4.5 times more likely to have testicular, esophageal, pancreatic, and stomach cancers, respectively. But those results were not statistically significant. So this study was the first to attempt to control for known cancer development risk factors, and there are certainly some limitations. The lack of significance for most of our results may be because of our low cancer case numbers. and limited power. For example, the melanoma risk for both the vitiligo and non-vitiligo groups was the same, but there were just 5 melanoma skin cancers reported among our set of vitiligo patients. It's also widely thought that vitiligo does confer protection against skin cancers, and we did find this trend, but it was not statistically significant. So for the skin cancer specifically, it's possible that an ascertainment bias manifested as patients with vitiligo who regularly see a dermatologist may be more closely monitored and have a more thorough skin health history taken compared to controls. So now let's review some past studies on skin cancer associations with vitiligo. In a study in Dutch patients, patients with vitiligo showed a 3-fold lower risk of melanoma and non-melanoma skin cancers. In a study of Italian patients, vitiligo patients had a relative risk of 0.24 and 0.19 for melanoma and non-melanoma skin cancer, respectively, compared to controls. However, in a study on Korean patients, skin cancer risk was increased in the vitiligo population with a 3.41-fold higher risk for melanoma and a 1.31-fold higher risk for non-melanoma skin cancer. But the skin cancer rates in the Korean study were overall lower than those of the European groups, suggesting that there may be an effect based on skin type or heritage. Nevertheless, the majority of the studies do support that vitiligo confers protection against all skin cancers, possibly due to the genetic and autoimmune profile of vitiligo, or perhaps the more vigilant sun protection in vitiligo patients. So in our ethnically diverse patient population, patients with vitiligo start with a protection from melanoma and non-melanoma skin cancers, and then after controlling for potential confounders, that protection largely disappears. For associations of vitiligo with hematological cancers, an NYU study showed that there was an increase in lymphoma compared to national incidence rates in the vitiligo patients. And our patients with vitiligo had lower prevalence of lymphomas, but ultimately vitiligo had a null effect on lymphoma risk when we accounted for confounders. And our vitiligo group had a nearly significant risk of leukemia. So regarding rates of internal malignancies, a study in Taiwan found that vitiligo patients had significantly increased ratios of prostate cancers in males, thyroid and breast cancer in females, and bladder cancers in both males and females. And also in a study on Korean patients, the vitiligo group showed significantly decreased risk of overall internal malignancies, and specifically decreased rates of colorectal, ovarian, and lung cancers. And overall, while our results were not significant, our findings for prostate, thyroid, breast, bladder, colon, lung, and ovarian risks did compare with these other studies. So the mechanism to explain why vitiligo might be protective of some cancers and predictive of others could be epitope spreading, where immune cells involved in targeting melanocytes acquire specificity for some tissue types, but not for others. And enhanced carcinogenesis may be seen in vitiligo patients because of the chronic systemic inflammation common in autoimmune diseases, as well as the frequent use of immunosuppressants to control the vitiligo. And on the other hand, decreased carcinogenesis may be seen because of the state of enhanced immune surveillance. So our future directions, these include using our database of vitiligo patients to examine the impact of UVB phototherapy on skin cancer risk, looking to see if unilateral, which could be a proxy for segmental, versus bilateral, which could be a proxy for non-segmental vitiligo, affects the cancer risk. We also want to look at the implications for cancer screening in vitiligo patients, maybe delve into some mechanisms involved, as well as it would be fascinating to look at the time course questions, like is vitiligo predictive or protective against future cancer events, as well as connections to the effects of cancer immunotherapy treatments. So here are my references and some acknowledgements. I really would like to thank Dr. Victor Huang for his mentorship, support, and teaching, as well as the UC Davis statistician team and the UC Davis Medical Student Research Fellowship, as well as the Global Vitiligo Foundation. Thank you so much for bringing us all together on this new platform. Thank you so much.
Thank you, Callie, for that excellent presentation. It was very interesting. I just have a question for you. It seems like there were, you found studies both ways. You found studies that showed an increased risk. You found studies that show a decreased risk. And as I was listening to your presentation, I was thinking, oh, should I check my patients for leukemia? Maybe, maybe not. Should I check them for lymphoma? Do I need to start doing lymph node exams? Maybe, maybe not. Melanoma I've always thought was decreased. And so even my very light skinned patients, I tell them there's not a risk for that. But then, we've seen some evidence in the Korean database, for example, it's increased. So it seems to me like right now there isn't really a firm recommendation of what we should be doing in terms of cancer screening, like we do for dermatomyositis, for example. So what are your thoughts about that?
Right. That is an interesting question in terms of how we can use this data to better inform our cancer screening choices. I think it will be interesting to continue our investigations on looking more at the confounding variables and seeing if we can figure out if there's anything, parse out the vitiligo patients in different ways to then assess their cancer risk. And I think with kind of the database we've been building, we might be able to get some more, specific concrete information on terms of, stratifying vitiligo patients on other characteristics, and that might help delineate the different cancer risks further. I think with, the more granularity and the more specificity that we can parse these patients out, I think we'll start to see some clarity on the cancer risk, and that can inform our screening choices.
Yes, and see those patterns. Well, thank you very much. In the interest of time, we can't take any more questions, but I appreciate that presentation. We look forward to seeing more data.